Good afternoon to everyone. We would like to thank you, everyone, for joining us today. It's especially an important day. It's America's Preparathon first day of service. So it's a very good group and time to start talking about dialysis preparedness as we enter into numerous seasons, whether it's tornado, wildfires, and also the hurricane season as well. I'm Kristen Finney. I'm a Senior Health Policy and the Analyst in the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Preparedness and Response. It's also known as ASPR. And I'm so pleased to be coordinating this important webinar in collaboration with ASPR's Hospital Preparedness Program, HHS's Centers for Medicare and Medicaid End-Stage Renal Disease Program, Joan Thomas from the Kidney Community Emergency Response Coalition, and our guest speaker and dialysis expert, Ms. Melinda Martin-Lester. As you may not know, there are approximately 450,000 individuals that rely on regular life-maintaining dialysis services across the U.S. Disasters, particularly those with water or prolonged power outages, commonly adversely impact this at-risk population. Historically, this population has experienced increased adverse outcomes, whether it be ED and hospital visits, and in some cases mortality. There have been significant advancements in emergency preparedness for this population since Hurricane Katrina. However, recent emergencies such as Hurricane Sandy have also noted that there's still questions about the unique needs dialysis patients may have and how best to anticipate and plan for those needs in our communities. We recently released the National Health Security Strategy and Implementation Plan. You can locate it at www.phe.gov for public health emergency. It recognizes the importance and is listed as a major objective in the plan about enhancing the integration and effectiveness of public health care and emergency management systems. We believe this important webinar today will begin to support broader awareness, understanding, and support for our dialysis-dependent community members. We're so fortunate again to have two speakers today join us. The first is Joan Thomas, who's a Certified Emergency Manager and the Director of CASER, the Community Emergency Response Coalition, and she manages emergency management initiatives throughout the U.S. and its territories for the kidney community. CASER is the virtual operations center during a disaster that includes coordinating efforts and resources for dialysis in an emergency. Joan has extensive management and consulting experience in developing and improving response capacities and operations, as well as continuity and disaster planning in both the public and private sector areas. Our second speaker is Ms. Melinda Martin-Lester, who has over 40 years of extensive clinical expertise, dialysis, service delivery, and operations management and development expertise in both hospital and outpatient settings, as well as corporate and private dialysis facilities. She's presented on numerous dialysis topics, whether international, national, regional, and local conferences and events, and is active in the American Nephrology Nurses Association, National Renal Administrators Association, and the National Kidney Foundation. In her current role as the Director of Compliance for Renal Ventures Management, she performs mock Medicare surveys, risk management oversight, and policy management. And prior to that role, she also worked at DaVita at Home as a business development specialist, where she coordinated the CKD program, education program in both Arizona and Utah, and developed and launched the nationwide in-center nocturnal hemodialysis program. She's also the former Director of Quality at the Renal Group for Western Arizona region and Oregon, and an area administrator for 7 outpatient facilities, 6 hospital acute programs, and 2 home PD hemo programs in Arizona as well. We've allotted today about 1.5 hours for this webinar, and if time allows at the end, we're hoping to be able to open up our calls to answer a few brief questions as well. The session is also being recorded and transcribed and will be available in the next few weeks on our public website that's located at http://www.phe.gov at /planning/planning/HPP/meetings/pages default. So we are grateful to both for providing their time and expertise today and your time for joining us on this important training. Without much further ado, I will now turn over the presentation to Joan Thomas. Thanks again.
Thanks very much, Kristen, for having us today. We also appreciate everyone who has joined us today to participate on this informative webinar. So before we begin, let's begin a few webinar housekeeping items. I'm sure you're familiar with most of these. To keep everything running smoothly, we'd ask that you please keep your phone muted throughout the presentation, and we've already muted you to avoid background noise. It's also helpful to keep the electronic devices away from your phone to eliminate any potential interference and echoing. And also, as a reminder, please don't put the conference call on hold, as we will hear your hold music, and we do appreciate your consideration with that. Questions are always welcome. We'll take breaks during the presentation for questions. So if you do have a question, please unmute your phone by pressing *1. So I'd like to give you a quick introduction on the Kidney Community Emergency Response Program, commonly known as CAESR. CAESR provides technical emergency management resources and assistance to end-stage renal disease networks, Centers for Medicare and Medicaid Services, and other stakeholders to ensure preparedness as well as timely and efficient response in an emergency or disaster for the dialysis community. As mentioned earlier, our webinar presenter today is Melinda Martin-Lester, who is the Director of Regulatory Compliance for Renal Ventures Management. I'm pleased to say that Melinda is also the chair of the CAESR Coordination of Staff Committee, who has been and is a great partner and asset to CAESR. Our objectives today are to provide a basic understanding of end-stage renal disease, known as ESRD, handling emergencies and basic emergency planning for the renal community, and how we manage dialysis patients in the shelter and during the triage process. I am now very pleased to turn this over to Melinda Martin-Lester.
Thank you, Joan. We're going to talk, we have about 3 parts to this presentation I'm going to do today. We're going to start and give you some general information about end-stage renal disease and then move on to the specific care of the end-stage renal disease patient. Next, Joan. Chronic kidney disease, or CKD, is characterized by 5 stages. And those 5 stages are the different areas through the life cycle of kidney disease. Basically, when patients reach stage 5, they are then considered needing dialysis or some other type of therapy, dialysis or transplant, and then they become end-stage renal disease patients. This is usually a very slow progressive onset. It's not something that usually happens quickly. Many of these patients can be in stage 2 and 3 for a few years. But when it reaches stage 5, it becomes irreversible and they have lost their kidney function, or at least enough of their kidney function so that they need renal replacement therapy. And that means an imminent need for dialysis or a transplant. So one of those options need to be available for patients in stage 5, because without that, within weeks, months, they certainly would expire from the complications of end-stage renal disease. Next, Joan. So with end-stage renal disease, the kidneys cannot function well enough to sustain life. And so what happens is the kidneys don't get rid of the fluids and toxins, and they accumulate in their blood. As they do that, patients become sicker, their blood values become out of kilter, and they are going to require some type of dialysis therapy. Once they go on dialysis therapy, they're going to require a special diet and additional medications to treat the end-stage renal disease, or to really treat the complications that go along with end-stage renal disease. If they happen to get a preemptive transplant or a transplant before they needed dialysis, they're still going to need medications to prevent the rejection of a kidney transplant. So even though a patient has a transplant, they still need some follow-up care, and in an emergency, they need to have access to those medications. If they do not have access to those medications, they will reject their kidney, and then they would require, once again, dialysis. So without treatment, their death is imminent. So, as I said, as they reach stage 5, they're going to have some kind of renal replacement therapy. Next, Joan. So in the United States, we have approximately 450,000 dialysis patients. Of those, the majority are on hemodialysis, and I'll explain the types of therapy as we get into the process of the presentation. This is the data from 2012. We had 408,000 hemodialysis patients and approximately 48,000 peritoneal dialysis patients. I'm sorry, 40,000. And then there's another 186,000 kidney transplant patients. When we're looking at end-stage renal disease, the major causes for kidney failure are diabetes and or high blood pressure. And these have been the major causes of end-stage of kidney disease for many years. In addition to those dialysis patients, we also have about 82,000 patients that are waiting kidney transplants. And we add to that list every year because on an annual basis, we usually only have about 18,000 transplants a year. So the number of patients waiting continues to go up. Patients can wait anywhere from 1 to 5 years for a kidney transplant. Most of these dialysis patients have other comorbid conditions, and it's really the comorbid conditions that cause the imminent death, because end-stage renal disease can be treated with dialysis or transplant. What doesn't treat it is the other comorbid conditions that go along that cause that dialysis need. So all of these patients are dialyzed in about 63,000 dialysis facilities, and then there's about 270 kidney transplant centers throughout the United States. So patients that are awaiting kidney transplant are on either one or two of the center's waiting list. They can be on more than one if they so desire. Next, Joan. So let's first talk about hemodialysis. And as I said, the majority of the dialysis patients are on in-center hemodialysis. That is, they come into a facility, whether it be an outpatient facility or a facility in the hospital as an outpatient facility, 3 times a week, usually Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and they run an average of 4 hours when they're in the center. So the amount of time they spend in the center comes to between 15 and 20 hours a week, depending on waiting time and just time to get into the center, time to get out of the center. We do have a small amount of patients on home hemodialysis, and that dialysis is done a little differently. Some of them still do the traditional 3 times a week for 4 hours, but then some of them do either daily treatment or every other day, and that treatment time really varies by the patient. That's a prescription that's set up by the physician. We do blood work to see how much dialysis the patient is going to need to clear the toxins and the waste from their blood. Any type of hemodialysis requires some type of machine and a water source. So we have to be able to plug in the machine to a separate 20-amp outlet, and we need to have water available to us. The traditional hemodialysis machine uses I'm trying to think how much they use per treatment. They use 500 cc's a minute as an average, and half of that water is put down the drain. So that means we need 1,000 cc's a minute to give them hemodialysis for 4 hours. So that adds up to a lot of water, and so we just can't hook into a water tank. We have to have a source of continuous incoming water for the hemodialysis unit. And that's one of the reasons in an emergency we may not be able to treat patients, because we don't have either water or power. The other type of in-center or home dialysis is called nocturnal dialysis, and that also requires a hemodialysis machine and purified water. But they actually come into the center at night. It's a much slower process, so they dialyze about 8 hours, 3 nights a week, or if they're home, they may dialyze every other night. But this is a gentler process, and it allows patients to have a much more normal life, in that if they work, they can come into the center at night, have their treatment, get up in the morning, go home, shower, and then go to work without interrupting their day. Not all dialysis units offer nocturnal dialysis. It's a small number. The normal dialysis facility usually treats patients from 5 in the morning anywhere to 6 to 10 at night, depending on how many shifts of patients they run a day. The other type of dialysis is peritoneal dialysis, and this is usually always done at home. There may be a couple centers in the U.S. that might do some outpatient peritoneal dialysis, but basically this is considered a home therapy. There's 2 types of peritoneal dialysis. One is CAPD, which is continuous ambulatory PD. What that does is that just puts fluid into the patient's body, as you can see from the picture. There's a patient with a tube in their abdomen and dialysate that's running in. There's no machinery involved. It goes into the patient by gravity. It's performed 24 hours a day, 7 days a week, and a patient does approximately 4 to 5 of these exchanges a day. One thing with peritoneal dialysis is they do have to have a fair amount of space for supplies because they use an average of a case of supplies a day, so they need a very large room or closet to store their supplies. The other type of peritoneal dialysis is continuous cycler PD. That is an automated system using a delivery machine. It does not require water, but it does require power. Usually CCPD is done at night, and that's usually 6 to 7 nights per week, approximately 8 to 10 hours a night. So they would hook up to the machine before they go to bed. They go to bed, the machine runs all night, and basically what it does is it runs fluid in, drains fluid out, and it does that for the amount of time the patient needs to be on the machine. And then when they get up in the morning, they disconnect from the machine, and then they can go about their daily business. The difference with this and CAPD is that for CAPD, you always have fluid in your abdomen, and usually that's between 2 and 2.5 liters. For CCPD, you usually only have fluid in your abdomen during the night, although some patients may require an extra exchange during the day. So for patients with back problems or other problems where they can't handle that 2.5 liters of fluid in their abdomen while they're walking around, the CCPD is a much better option. In addition, it also is a better option in that it is done, as I said, at night while they're sleeping. Next slide, Joan. The other type of renal replacement therapy then is transplantation. And what they do in transplantation is, as you can see from the slide, they don't actually, in many cases, remove the patient's native kidneys. As you can see at the top of the slide, the kidneys are still there. Those are their native kidneys, the two on the top. Down below is the donor kidney, and that is usually put into the pelvic area. The reason they put it there is that the pelvic area protects it, and then it allows it to be connected into the bladder directly, and then it's connected into the blood vessels so that it's easy to get in to if there's a complication, and as I said, the pelvic bones can do some protection of that kidney. Once that kidney transplant is in place, patients have to take special drugs to prevent the rejection of the kidney, and in many cases they're taking those drugs for the rest of their life. If they decide they're going to quit those drugs, that kidney can reject pretty quickly, and then they would need, once the kidney rejects, if they're not able to correct it very quickly, they're going to lose that kidney and have to go back on hemodialysis or peritoneal dialysis. Some of those medications do diminish the body's ability to fight infection, so our transplant patients have to be very careful, especially when they're on higher doses of steroids, so they don't come in contact with people that have colds or pneumonia, because you don't want to get an infection that may also cause damage to the kidney. So we encourage them to avoid exposure to infections. As that kidney stays in there longer, the amount of medication sometimes decrease, and they don't have that as big a problem with infections. But it's always a risk anytime you're taking any kind of steroidal medications that can affect your white blood cell count. Next, Joan. So those are the 3 types of therapy that our dialysis patients are on, and those are the types of patients that you're going to see coming in, that you would see coming into the shelter or needing care or at least some assistance in an emergency. So now we're going to talk about end-stage renal disease and emergencies and how best to treat our patients so that they remain healthy. Next, Joan. So when we're looking at ESRD emergency considerations, there's some things that we have to run a dialysis unit. So in an emergency, these things are sometimes short-circuited. As I said, we need specially trained staff. We can't just pull people in out of the hospital from other departments. They have to be people that are specifically trained in dialysis, and those would be nurses and hemodialysis technicians. We have to have electricity, and we have to have an electrical source that will allow us to run treatment for 3 to 4 hours. In emergency situation where we may have to treat a lot of patients, we may shorten their dialysis treatment a bit, maybe to 3 hours, so that we can get more patients into the facility. As in, during some emergencies, sometimes dialysis units are damaged and they're unable to take patients, and we have to send them elsewhere. And then we have to have safe water. Any type of a public water supply can be used, but we also then have to filter that water with a special reverse osmosis machine to remove substances such as chlorine, aluminum, and fluoride. And all of these substances, if not taken out of the water, can leach into the patient's bloodstream through the hemodialysis filter. Dialysis units also, if they're going to run and there's a power issue, need generators. Not all dialysis facilities have generators. Specific states require generators, but not all of them. And one of the things that we found out in Hurricane Sandy is it's great to have a generator, but if you can't get fuel to the generator, because most of them are gas-powered, we still can't run. Most generators also run for a very short time before they run out of fuel, so we're very limited in our generator time unless we have a large amount of fuel available. And in some emergencies, snowstorm, ice storm, hurricanes, the trucks can't get to the dialysis unit to refuel them, so the generators still are not usable. Next slide, Joan. Also, it does take longer and more resources to set up a temporary facility than to restore an existing facility. With the water systems that we need, the type of power that we need, it's very difficult to go into a makeshift building and use it for dialysis, in that we aren't going to have enough water treatment units, or we're not going to have enough power. And then lastly, our patients may need shelter, but there really is no dialysis in shelters. A dialysis unit is a very specialty setup. It requires a lot of money to put up a dialysis unit. Average cost of a dialysis unit is anywhere from $500,000 to $1 million to set up a 20-station dialysis unit. So it's not something we can put together very quickly. Next slide, Joan. So some of the challenges that we've seen in the emergencies we've had in the past certainly are transportation. Many of our patients rely on county transportation or public transportation to get to their dialysis treatment. And in many cases during an emergency, those types of transportation are not available, and that is pre-emergency and post-emergency. As we see a snowstorm coming in or an ice storm, local community transport may quit transporting patients because of the safety of their drivers and of the patients. And then in that case, county transportation can be very limited. Secondly, we have communication challenges, contacting emergency management, getting our utilities back on, both in the dialysis facility and for our home patients. And then lastly, in communications, is just keeping track of our patients. We certainly encourage our patients in an emergency, if they're going to go somewhere else, such as if a hurricane is coming and they live in Florida and they're going to go visit their family up north because they don't want to get involved, they need to call us to let us know where they are, because we don't really know if they don't let us know where they are. And certainly CASER and our local ESRD networks helps us with trying to locate our patients also. And then lastly, those challenges in power outages in terms of both electricity and loss of communication. Next slide, Joan. We talked a bit about generator and the fuel issues, and also we talked about water. And as I said, we use approximately 80 to 100 gallons of potable water per patient per treatment. So it's a large amount of water that we have to have available. And then lastly is security of the dialysis facility, and then security in terms of making sure that we can secure our buildings when we're not there, secure our equipment when we're not there, and as I said, have communication. Next slide, Joan. So the third part is to talk about some emergency planning and what the different stakeholders do for dialysis patients to prepare the dialysis facilities and our dialysis patients for an emergency. Next slide. So here are some of the basics of emergency planning. End-stage renal disease networks. There are 18 networks in the United States, and each of those networks help assist providers in developing local disaster plans. They track in emergencies, they track the status of the dialysis facilities in that we communicate with the network to let them know if our facilities are going to be closed or they're going to be opening later, or that they aren't going to be able to take patients, or that they can take patients in emergency. So the network really serves as a clearinghouse for all the dialysis facilities to keep track of the types of facilities that are available to patients. And then lastly, the networks work really hard to increase awareness of the needs of our end-stage renal disease community. As a facility, the facilities are responsible for developing written policies and procedures and then training their personnel on what to do in emergencies. We all have to do mock disaster drills, mock fire drills on a routine basis to make sure we're ready to help our patients in an emergency. If we know an emergency is coming, such as a hurricane or a storm, we may bring our patients in a day early so that we can get them treated, and maybe the next day, the day that's expected to be the worst day of the storm, we may not have to treat patients. So in many cases, we may bring all of our patients in on a Monday or a Tuesday so that maybe we don't have to treat them on Wednesday, and then by Thursday things are better. So anytime we have advance notice, we work very hard to get all of our patients in and treated. And it may be a shorter treatment, but it'll be something that will help them last for a couple of days if an emergency or a disaster hits. We also are responsible for educating our patients, our nephrologists, and the community as to the needs of our patients and what we need if there is an emergency. Next slide, Joan. Patients are responsible for developing a personal plan. We want our patients to be prepared. We provide them information on development of a plan, what they need to do, what kind of foods they need to have available for an emergency diet, what kind of medications they're going to need, and other things they're going to need in an emergency. We want them to be able to be self-sufficient for up to 7 days post an event, because it may mean that they may not get treatment for 3 to 7 days after a disaster, depending on the magnitude of that disaster. So if a hurricane season is coming up, all of our patients in a hurricane area are educated on hurricanes. They're given another copy of their disaster plan, of the disaster diet, and who to call if the dialysis unit is closed. And then the renal community themselves participate in coalitions such as CASER and other healthcare coalitions doing some emergency drills. And then we also work with key stakeholders to educate and advocate for the needs of our end-stage renal disease patients. And certainly my work and the dialysis units work with CASER are really looking to educate and help our patients in time of emergency. Next slide, Joan. The dialysis facilities in terms of community education provide, as I said, emergency plans to patients, staff, and nephrologists. And then we also have backup facility plans. So all of our facilities have a backup dialysis unit. So if they happen to have to be closed for some type of emergency, there's another facility that has agreed to take their patients. And that backup plan is put into place, and then those patients are transferred to that backup facility. Now, if the backup facility is damaged, we then have to help our patients find another place to dialyze. But that's why we have emergency plans. We keep contact with our patients. We encourage them to call us. So we educate our patients on a routine basis as what they need to do in a disaster. Our social workers and staff also can help patients assist with getting into a shelter if for some reason their home is damaged or they can't go back to their home. As I said, we provide them education regarding the emergency diet and fluid restrictions, because when they're not receiving dialysis, any fluid that they drink will stay within their body, which means they're going to get short of breath if they don't restrict their fluid. We also provide them with those emergency contact numbers. Many large dialysis companies have an emergency hotline that patients can call to find out the status of their dialysis unit. Some of the smaller providers have an emergency number that patients can call so that they can help get them into a dialysis treatment center. Next slide. So we want our patients and families to be fully informed of the facility emergency plan. So as I said, everybody gets a copy. We want them to know where they need to go, what they need to do, who they need to contact. We want them all to develop a personal preparedness plan. We want to make sure they have enough medications, that they understand their diet and fluid restrictions. And for home hemodialysis patients, we want to make sure that they have supplies so that they can continue their dialysis. So say a CCPD patient that runs on a machine, if they have problems with power, they have supplies available at a home to switch over to the ambulatory method, which does not require electricity. So we want all of our home patients to have that supply of CAPD supplies, which are different than the CCPD supplies. And really we want our patients to be self-sufficient. But we all know that in emergencies, everybody's going to be calling for assistance. So we just want them to feel comfortable that we are going to help them during an emergency. Next. So if there's any questions, is everyone clear on the 3 treatment modalities, some of the challenges that we face, and what the roles of the ESRD providers play in emergency preparedness? If anybody has any questions regarding those items, they can go off mute and ask me the question. Otherwise, we'll move on.
As a reminder, if you'd like to ask a question, please press *1, unmute your phone, and record your name clearly when prompted. One moment, please, for any incoming questions.
Okay, then I guess we'll go on. Joan, next slide.
Okay, you're ready, Melinda.
Okay, next slide. Great. So now we're going to talk a little bit about if a patient does show up in a shelter, how the shelter staff can help manage the patient and help understand what the patient's needs are. So we're going to talk a little bit about the vascular access for hemodialysis. For our dialysis patients, the vascular access is really their lifeline. And so we want to make sure that that vascular access is taken care of and that people are aware that a patient that's on hemodialysis has some sort of vascular access that needs to be monitored and taken care of. There are 3 types of vascular access that we use for hemodialysis: an AV fistula, arteriovenous fistula, arteriovenous graft, or an AVG, or a central vein catheter, which is a CVC. And we're going to talk about, you're going to see pictures of each of those. Next. So let's first talk about the arteriovenous fistula, or the AVF. The fistula is basically using the patient's native vessels to make an access point where we can access the patient's bloodstream for the hemodialysis. And what happens is they connect an artery and a vein together. And if you look down here by the artery, you can see where that connection occurs, and then what happens is that arterial blood goes into the venous area, and it causes the vessels to get bigger so that we can put needles in their arms. Hemodialysis needs 2 needles put in the fistula, one in the artery section and then one in the upper section, which is the vein. We pull the blood out of the artery. We return the blood back into that vein section, and that happens throughout the treatment. This has to be a big enough vessel so that we can run about 500 cc's a minute of blood through the dialysis filter and return that blood back to the patient. If we do not get that large amount of blood, we're going to have trouble giving them adequate dialysis. We also, because of that blood flow, are going to use much larger needles than you would use to, say, draw blood on a patient. Most times when you go into the hospital to get your blood drawn, they're using a 21 gauge needle. We actually use needle gauges in the 14, 15, and 16, which are much larger, which means that's why you need a bigger vessel to put the needles in. So this is using the patient's native vessel. And what we want to do is we want to be careful that if that vessel is in the lower part of the arm, that they're not having any constrictive clothing that's going to cut off that fluid, that blood flow. And we also want to make sure that they don't sleep with their arm bent, because that also can cut off the blood flow. All of our patients are taught how to care for their access. What we also don't want to happen is we don't want blood drawn out of that access, because that can also damage that hemodialysis access. Next. The next access is called an AVG, or an arteriovenous graft, and in most cases those are loops, and what happens is they take a piece of a Teflon or a polypropylene material, and it is inserted under the skin. It's connected to an artery, which is that red area, and then it's looped around and then connected to a vein. So that can either be a loop graft or it can be a straight graft. It could be in the lower part of the arm. It can be in the upper part of the arm. And so we have the same concerns and issues with this, and we don't want it to be cut off. We don't want any restriction on it. We want to make sure if patients have that come to the shelter and they have a Band-Aid on it, that those Band-Aids are not left on for over 4 hours. We want to make sure that we can access that vessel. We want to make sure that excuse me, the staff can feel that vessel to make sure they feel a pulse through it. Because it's such a high flow, you're going to get what we call a brewery. If you listen to it with a stethoscope, you're going to hear a little whooshing noise, and then you're going to feel that thrill, which is that pulse that's running through the vessel. And it's much different than taking somebody's pulse on their arm. The last type of access, and this is the type of access that we prefer most of our patients not to have, but many of them do have it because they've come to dialysis without pre-planning, and they weren't able to have placement of a AVF or an AVG. This is a plastic tube with two, I'll show you a picture in a minute, with an arterial side and a venous side. It's placed in either the internal jugular vein, the external jugular vein, or in some instances it's placed in the subclavian. We do try to avoid that subclavian vein if possible because it tends to get stenosed, and that causes more problems for the patient. The other type of a CVC, or a central venous catheter, is put in a femoral vein, and it's very similar to what you put into the vein up at the top. We're going to insert it into the femoral vein. This catheter is going to have two arms on it. One is going to be an arterial arm, which is red. One is going to be a venous arm, which is the blue. So we're pulling the blood out of the arterial side and then putting that blood back in through that catheter in the femoral vein. We see very few femoral vein catheters. That's usually only put in patients that they're on their last access and they really have no other place to put any type of a dialysis access. So patients that may have been on dialysis a very long time and have exhausted all the other places on their arms and their thighs for accesses may end up and have to get a femoral vein catheter, but these are very infrequent. So, as I said, for vein presentation, when our patients are originally diagnosed with chronic kidney disease, we want to make sure that we preserve those veins in their arms, and then we want to protect them for future vascular access. So even though a patient may have an access in their right side, we're going to also take care of the left side, in that if that patient's access clots, we may have to go to use the left side. So all of our patients are taught that they've got to be very careful when people take their blood pressures. You want to make sure that you don't leave tourniquets on for a long period of time, because all of that can impede that blood flow. So we want to protect that patient's access from injury. We want no blood pressures on their access arm, IVs, or blood draws. We don't want them carrying heavy items such as a purse or have tight jewelry on, and we want it used just for dialysis. Some people look at that access and say, oh, wow, this is a great access, we can draw some blood from it. But our patients are told not to let them draw blood from it, because anybody that doesn't really understand that type of access can damage that access if they try to draw blood from it using traditional needles. Next. So the other thing that has to be done when patients end up in shelter is there has to be some sort of a clinical assessment. You want to know when the patient had their last treatment. You want to assess fluid status. You want to look at their eyes. Are their eyes swollen? Or do they have edema, pedal edema on their ankles or on their legs? And in some cases, they may have some edema, but you need to ask the patient, is this usual? Because some patients have edema all the time. Other patients do not. So it's very important to talk to the patient, ask them, what's their normal type of edema? Do they usually not have it? And then same with shortness of breath. Do they always have shortness of breath, or have they just become short of breath recently? You want to listen to their lungs to see if they have any rales or bronchi. You want to basically ascertain what that fluid status is, because as that patient continues to take in fluid and not receive dialysis, it's going to continue to accumulate in the body, and it accumulates as edema or it accumulates in the lungs, and they become increasingly short of breath and increasingly uncomfortable due to that edema and shortness of breath. You want to take their blood pressure and pulse. You want to ask them what their normal blood pressure is. Some patients run normally a high blood pressure. Some patients run a low blood pressure. If they tend to have a high blood pressure, it's only going to increase as that fluid increases. And then you want to see if their pulse is thready or if it's rapid. You don't want to use their access arm to take that blood pressure. But as I said, you want to ask the patient what's normal. Most dialysis patients can tell you what their normal blood pressure is when they come in for dialysis, or what their pressure is when they leave dialysis. So usually they come in with a higher blood pressure. As we take that fluid off, their blood pressure comes back down. You want to also make sure if they're on blood pressure medications that they're taking their blood pressure medications. And as I said, you want to see that their heart rate is regular. Next. You want to assess them for affection. Do they have a temperature? When you're looking at their access, does the access look red? Is that catheter site clean and dry? Patients that have those central venous catheters will most likely have a transparent dressing over that catheter, which is usually changed every week. We put the transparent dressing on so that we can see the access without having to take the dressing off. It's really important that if they leave that dressing on, but that somebody is looking underneath that dressing. You want to make sure that the catheter caps are still on there, and that the little clamps that are on the access are closed. Because if one of those catheter caps come off, the clamp is open, they're going to have blood that comes out of that catheter. You want to look at the peritoneal dialysis catheter site, and that is going to be in the abdomen. Is that clean and dry? Our patients are taught how to clean that site daily. They clean it with soap and water or some antibacterial solution, depending on the facility and what their policies are. And also for your PD patients, you want to make sure that their abdomen is not firm or tender to the touch, because that also can mean that they have an infection. Also, as they're draining out their fluid, if the fluid is cloudy or bloody, they also could have an infection. Any of those types of things, especially for peritoneal dialysis patients, if there's an infection, they need to get to the hospital as soon as possible to get started on antibiotics. And same with our hemodialysis patients. If there's an infection in that catheter, there's redness and there's pain, or there appears to be an infection in their fistula or a graft, they need to get to the hospital to be treated so that the patient does not lose that access. Next. So what we prepared, my committee, our CASER committee, put together a shelter triage checklist for dialysis patients, and this checklist is available on the CASER website. And it just sort of goes through some of the things that you need to be looking at when you're evaluating patients. And what it's saying is if you're checking off more than just a few pieces on this, it probably means the patient needs dialysis and they need to go to the hospital. Because certainly confusion, agitation means that the toxins are collecting in their blood. Shortness of breath means that fluid is collecting. Same with the cardiac assessment, that irregular pulse. Nausea and vomiting usually means that their BUN and creatinine is elevated. As I said, a firm or tender abdomen for a PD patient means they probably have an infection. And then, as I said, we want to look at those catheter sites. We want to look at their edema. Are they having any cramping, redness around their sites? So these are just some things to bring to the attention of the medical staff in the shelter when they're looking at our dialysis patients. And as I said, these are available on the CASER website. Next. Another thing with our dialysis patients, if they're not getting dialysis, they're going to have to restrict their diet and fluid even more than normal. A normal dialysis patient has a restricted diet and a fluid restriction. If someone is not going to get dialysis for a couple of days, it's very important that we further restrict that diet and fluid. And you have to remember, fluid is anything that's liquid at room temperature. Ice cream, Jell-O, ice cubes, all of that adds into their fluid. And in most cases, we try to limit fluid to 2 cups a day. But you've got to remember that 2 cups in means that 2 cups every day is going to stay in the body until they have dialysis. Most dialysis patients do not have fluid output. Our patients, as I said, are given an emergency diet, which lets them know what types of foods they should be eating and in amounts. And we encourage them, if they go to a shelter, to bring that emergency supply of food with them, because those are foods that are selected by the dietitian as something that they can eat and will not cause them to have further problems. They need to avoid any foods that are high in potassium and salt, because potassium can affect the heart rhythm. So foods that are high in potassium, as we're not going to remove that potassium without dialysis, can cause their pulse to become erratic. And if a potassium level gets too high, it can cause the patient to go into cardiac arrest. And in addition, we want to control the amount of salt, which means we want to control the amount of processed foods, because that salt leads to extra retention of fluid, causing them to be increasingly more short of breath. Next slide. So these are some of the foods that are very high in potassium. All of our patients are educated on the types of foods that they should not eat or should eat in very small amounts. But many of these foods are very high in potassium. Beans, peanuts, soybeans, potatoes, dried fruits, avocados, any type of a cantaloupe or a honeydew. They can have watermelon. It doesn't have the high potassium that a cantaloupe would have in it. Bananas are especially high. Squashes, pumpkin, beet greens. Milk is high in potassium. Milk is also high in phosphorus, which is something else that they have to control. Tomatoes are very high in potassium, and any kind of citrus fruit, oranges, lemons, grapefruit, are very, very high. Our patients are told to eat these in very, very small quantities, whether they be canned or fresh. Next slide. So, any questions about the types of vascular access, why we need to preserve their veins, what patients can do to protect their access, or some of the diet and fluid restrictions? We talked a little bit about what are some of the main things we want to restrict with our patients, and as I said, that's usually fluid and potassium and salt. So you could open it up to questions.
Okay, thank you. Again, if you'd like to ask a question, please press *1, unmute your phone, and record your name at the prompt. One moment, please, for any incoming questions.
Hi, this is Joan from CASER, and what I noticed in the chat section is people are asking about the presentation slides, if they'll be available. And I know Kristen Finney had mentioned where they would be available. Kristen, would you be able to let us know where they can access them in the next few weeks?
Sure. We have a flyer. If you want to actually email me, I can also send it to you in case it's a kind of a wordy thing. You can send it to me at kristen.finney, F-I-N-N-E, at hhs.gov. But it's also located at, you will be able to find it at www.phe.gov/planning/HPP/meeting at that site.
Are there any other questions?
I'm showing no questions on the phone.
Okay, that is actually the end of the presentation. So Joan, you can put up the last slide, which has information on how to contact myself, Joan, Angelo, who also works with Joan at CASER. It shows you some of the websites down at the bottom that are available for education and more information about dialysis patients and dialysis facilities, types of access, and anybody can email me if they want any additional information also. So as I see, I talked very quickly. Showing the last slide, which is talks a little bit about CASER. And that's it.
We just had another request for the website. If you could repeat that again, Kristen. I don't know if they can search for this meeting under the phe.gov site. Is that possible?
I'm not sure, but I can find out, and we can send a flyer out that has the actual link in it. We have another flyer that we can send, so I'll send that out to you, Joan, for those. Again, it's www.phe.gov/preparedness/planning/HPP/meetings. You can also email myself, Kristen, Kristen.Finney, F-I-N-N-E, at hhs.gov as well.
And certainly anybody can also contact the local end-stage renal disease networks. You can find them also online in what states they cover. So if you want to work specifically with a certain state or a certain area, the ESRD networks are really a good resource also.
And that's showing on this slide here, www.esrdncc.org.
And I do want to just, this is Kristen Finney, I just do want to encourage everybody again on the call, please check out these websites. The CASER website especially is an incredible tool that has so much information, readily available tools and information that you can use, whether it's from a provider to an individual to an emergency responder and such. So as well as your networks, as well as also, connecting with your public health departments and such. And if there's other information and questions that come up after this presentation, sometimes we don't always think of them right away, please do feel free to reach out, and we will accommodate by trying to send out more information to address any other additional questions.
And excuse me, we do have one question coming in on the phone.
Wonderful.
And whoever has a question, please go ahead. Your line is open. You didn't record your name. Please check your mute button. There you go. Open. Your line is open now. I think they're bashful and don't want to ask their question now.
Well, certainly, if they have a question, they can email me, and I'm more than willing to answer it.
When you press that one, it opens the line.
Your line is open. Did you have a question?
No, not right now.
Okay, thank you. And other than that, there are no further questions.
In that case, I think I'd like to thank both Joan and Melinda for providing an extremely informative session and providing, general awareness and understanding of the unique needs for the dialysis patient within the community. And I can't tell you how much I appreciate it, and also participating on this important day in America's Preparathon. And hope to have more collaborations and information that we'll be bringing forth to you regarding this population and community in the future as well. So I just want to say thank you from the behalf of ASPR and HHS in general for all your time and expertise and support to this extremely at-risk population as well.